I should have just done my own version because what I would have said is like Dr. Maski is one of the most incredible colleagues to work with and one of the most respected doctors and researchers in the space. And it's always a good privilege to have her come speak, but I should stay on script, shouldn't I? Okay. Dr. Maski is an associate professor at Harvard Medical School and a child neurologist and sleep medicine specialist at Boston Children's Hospital. Dr. Maski's clinical work and research is focused on CNS disorders of hypersomnolence, and she served as the co-chairperson of the American Academy of Sleep Medicine Task Force for the treatment of central nervous system hypersomnias. Task Force member also for the International Classification of Sleep Disorder version 3, and the chairperson for protocol development for the MSLT and MWT in children. She is a member of the medical advisory boards for Wake Up Narcolepsy, the KLS Foundation, and the Hypersomnia Foundation. Her research on sleep diagnostic and prognostic biomarkers has received grant support from the National Institutes of Health, the American Academy of Neurology, American Sleep Medicine Foundation, Wake Up Narcolepsy, Boston Children's Hospital Research Council Fund, and Jazz Pharmaceuticals. She's the 2024 recipient for the Research Pioneers Award from Wake Up Narcolepsy for her research in pediatric narcolepsy. Welcome, Dr. Maski.
Thank you for that very kind introduction. So I've been tasked to talk to you about the pathophysiology and some emerging therapies for idiopathic hypersomnia and narcolepsy. This is a little bit of a hard ask because you haven't gotten any preparatory sort of slides about what these conditions are. But I think you'll be getting a lot of biology and neurophysiology later in this forum. So these are my grant disclosures as well as conflicts of interest. I, of course, will always endeavor to provide balanced reporting. So as you probably know, we classify these conditions under the heading of central nervous system disorders of hypersomnolence, of which narcolepsy type 1, narcolepsy type 2, and idiopathic hypersomnia are one entity. Oftentimes they're linked by just very severe daytime sleepiness, but we know that there's unique symptoms to idiopathic hypersomnia, such as sleep inertia, long sleep duration, which I'll get into. In terms of idiopathic hypersomnia, I think most experts think of it as almost two different conditions. One is really where the patients are very sleepy, almost just like narcolepsy patients. And it's easy to quantify that on things like the multiple sleep latency test, which I'm sure a lot of you have had. And when people are that sleepy, they almost overlap with symptoms of narcolepsy. So there's been a movement to maybe even consider this a narcolepsy syndrome or spectrum disorder and kind of quantify or classify patients into that. However, the vast majority of patients, at least based on billing diagnoses, seem to have this long sleep phenotype, which is different. The patients that look more like narcolepsy oftentimes do feel like they sleep a normal duration of time. And patients with long IH, basically long sleep duration, tend to report sometimes milder daytime sleepiness and oftentimes might not meet the qualifications on the MSLT for hypersomnia disorders. They oftentimes report severe sleep inertia or drunkenness, just difficulty getting up and going in the morning. It can take almost an hour or more to get up and kind of get going. Really crippling fatigue. Unrefreshing naps. And when people do nap, they tend to have very long naps that are difficult to emerge from. And there is also a tendency for delayed circadian rhythm, meaning that people tend to go to bed later and wake later too. So in terms of the overlying causes of idiopathic hypersomnia, as you might know, idiopathic means we don't know. It's a fancy word for that. But people have been trying to find causes that might be at least contributing to the symptomology I reviewed. One of those might be genetic causes. And so this is really based on studies that have shown that patients with idiopathic hypersomnia oftentimes have relatives who are very sleepy or have narcolepsy or other idiopathic hypersomnia-like symptoms. And so these studies that are done in large quantities of patients are called gene-wide association studies, or GWAS. And this is almost like a screen of the genome to see if there's any little variance in the genome that might be explanatory for conditions like hypersomnia. This study was done in Japan primarily, where there might be more patients that are similar and might yield better results for types of genetic studies for that. One of the results that came out was that there was a problem with a gene that was necessary for the orexin system. So orexin is a neuropeptide we'll talk about shortly that's really important for wakefulness. And what was found here was that there was a gene mutation in a parent compound of orexin that prevented it from being broken down properly and usable. However, this would only explain 1.6% of the patients, so a very small number of people could have this particular explanation. Other genes that this group had found would be things in cell signaling, so the PDE9A gene. This is involved in sleep regulation as well. It's also been reported to be abnormal in Alzheimer's disease and sleep problems. But again, this explained a very small number of cases. And then patients are always asking me about metabolic causes for their conditions or something I can take dietarily or whatnot. Here they did find that there was a problem in a small number of people, again, with a fatty acid oxidation gene. And this is basically a gene that breaks down carnitine into fatty acids so that your mitochondria, your energy workhouses of your cells, can use it for energy production. They found that there was a mutation in the enzyme that's involved in that breakdown, but again, affecting only a very small number of people. And I think one of the common questions I ask is, should I be taking carnitine? Because this comes up on chat groups and whatnot. And we have no evidence for that, but in this particular case, it would be dangerous for these people to take carnitine because it wouldn't be broken down properly. Other types of genetic testing that's done is called whole exome sequencing. This is where only about 1 or 2% of the genome is actually coding usable proteins. So it's focusing on just those 1 or 2% of the genes. And in this study, which was done in France, they found that there was a mutation in what's called the period 3 gene, which is necessary for circadian rhythm development. And so the thought was maybe if this was mutated, there could be an explanation for why patients have the problem, and this would be a circadian or clock-like cause of the cells. However, this was, again, only found in a very small number of patients. And then lastly, at least based on animal data, they found that there's these compounds called microRNAs. So when your body makes proteins, there's these microRNAs that work with RNAs to kind of modulate the proteins and how they act and look. And they found that manipulating these microRNAs could cause problems in how orexin was expressed. They have started to look at this in human studies. So in terms of circadian causes that I mentioned, remember the circadian clock is sort of our regulatory system that every animal has essentially to regulate function. And what it's really trying to do is keep our sleep and wake states consistent with our environment, like the sun exposure. So biologically, we want to be awake when the sun is out, and we want to be asleep when the sun is down and it's nighttime. There's probably very adaptive reasons for that. So when we're talking about circadian rhythms, we're oftentimes talking about your circadian period. And this is basically your night-day-night cycle. Day-night-day cycle, so a 24-hour period. And the human biology, actually, if we measure this clock rhythm, actually runs a little bit longer than a 24-hour day, so 24.2 hours. And this can vary between people, of course, but this is the average circadian period that's been reported. And so a research group looked at this in idiopathic hypersomnia and found that at least the patients that they tested had a longer circadian period, meaning that they just had a longer biologic night, which might explain sometimes long sleep duration and really difficulty waking up because essentially their sleep-wake is longer than the day, if you will. And when they looked into the expression of what genes might be causing this, they found that the expression of BMAL and period genes, so just to go back, period and cryptochrome genes are things that are expressed at nighttime to promote sleep, and then they're basically degraded, their products are degraded in the daytime, and then BMAL and clock are 2 genes that start to get expressed during the daytime to maintain wakefulness. So it's sort of like a little flip-flop switch. And they found the amplitude of these genes was about half the amount of other healthy controls, suggesting that maybe that this genetic expression is contributing to long circadian periods, long biologic nights, if you will, contributing to it. So this is something that needs to be replicated, obviously, but really interesting. Patients oftentimes ask me, is there a chemical in my brain that I'm missing? And we know that in narcolepsy type 1, people are missing, if you will, orexin neuropeptide, which is important for wakefulness. But this has not been found in idiopathic hypersomnia or narcolepsy type 2. So you'll get another lecture all about the biology later, but just very briefly, when we want to sleep, there's a compound produced by an area called the VLPO in the hypothalamus part of the brain that increases GABA. So GABA is sort of our sleep substance, if you will. And essentially GABA and its related compounds will inhibit orexin, so you don't want to be awake when it's time to sleep. And then it will also inhibit other wake-promoting neurotransmitters like dopamine, serotonin, and norepinephrine. So a group in Emory really has shown that, at least based on human studies, when they looked at the spinal fluid of hypersomnia patients and applied GABA to it, they found an increased uptake of GABA by that spinal fluid, suggesting that they might have increased receptor potentiation, sort of souped up receptors for GABA, if you will. And interestingly, they also showed that when they added a blocker to GABA, flumazenil, that it actually blocked that effect. And medications like clarithromycin, you might know as medications for antibiotic use, actually are negative GABA modulators. And so that was a clinical trial that was done showing that it can be effective for improving symptoms of daytime sleepiness, among other things, among the IH group. However, results of this study weren't replicated, and so it's still an unanswered question. Others have looked at various chemicals that promote wakefulness. So is dopamine, serotonin, and norepinephrine abnormal, and that's what causes problems? That has not been shown, nor has their metabolites that make up those neurotransmitters been shown to be abnormal. So unfortunately, we're sort of still left with unknown reasons. Of course, it's important to continue the search for why patients have idiopathic hypersomnia, so we get closer to more targeted therapies. And there's a number of researchers working on that, looking at various things like metabolomics, sort of small compounds that might be contributing, genetic causes, as well as the circadian thoughts I shared earlier. Moving on to treatments, just to set the stage for the types of treatments that we're looking at, basically wake-promoting neurotransmitters are typically monoamines that are things like acetylcholine, histamine, dopamine, serotonin, norepinephrine, and all of these are wake-promoting neurotransmitters that help us with arousal. Orexin is a sort of, if you will, master regulator of these compounds, and that they're sort of, orexin acts to kind of keep a finger on the switch of all of those other neurotransmitters so that there can be sustained wakefulness. And I mentioned it a couple of times throughout these talks. The other thing to know as we talk about emerging therapies is the different phases of clinical trials. So phase 1 studies are usually done in either healthy controls or small groups of patients, looking at sort of just the safety of a compound. Is it safe to use? It also can help with identifying the dose of the medications. Phase 2 studies are usually then taking those successful compounds and evaluating it for the efficacy, does it work, as well as the safety compared to placebo. Usually those are larger studies and those can take months to years. Phase 3 studies are usually even larger studies. They usually are also looking for efficacy. They might have larger endpoints that they're looking at. They might be compared to standard therapy, for instance, pitolisant next to modafinil, but they could also be placebo-controlled trials, and they're usually larger and longer. At this phase, usually a company has enough data to go for a review to the FDA to get the medication approved or not. And then optionally, some companies would opt to do a phase 4 study, which is really a real world study. So now the medication is used. Is it actually useful over longer periods of time? Are there minor side effects that pop up over time? These are really important questions. This is also a phase where potentially the inclusion criteria might be broadened, and potentially that could be for phase 3 as well. Other outcomes that come up in these clinical trials are things like the maintenance of wakeful tests. So this is a test. I don't know, has anyone in the room ever had this test? Yeah, a few people. Usually it comes up in clinical trials, really. And so this is essentially a test that is used to assess wakefulness. And this is my diagram from ChatGPT. Thank you very much. If it looks a little funny. But basically, this is a study where a patient is put into, or a participant in a study is put into a semi-reclined position. It might be a chair, it might be a semi-reclined bed. And then they're asked to stay awake for up to 40 minutes. And then there's 4 trials of that across the day. The room is dimly lit, the room is quiet, and essentially what we're looking for is how long can a person stay awake until they start to feel drowsy. And those leads that you see on the head are basically measuring that different states of drowsiness to sleep. So normal, like the optimal, is usually 40 minutes, just to set the stage. I don't even think I have a 40-minute wakeful test right now, but a 30 minutes and above is considered pretty normal. Other things that probably people in this room have taken as part of clinical care are things like the Epworth Sleepiness Scale. This is 8 questions that are asking about how sleepy you are in passive and active situations. Momentary sleepiness scales, like Karolinska scales, are basically asking how awake or sleepy are you right now? And then there's surveys that are becoming really important, especially in idiopathic hypersomnia, like the Idiopathic Hypersomnia Severity Scale, that's asking about questions beyond just sleepiness, things about sleep inertia, things about long sleep duration, things about how you're functioning every day with the symptoms. And it's trying to push, beyond, again, that just sleepiness question. And then other cognitive measures. We've heard loud and clear from patient groups and everyone and providers that people really care about how the treatments affect their ability to think through the day. I can stay awake, but my eyes are open, I'm not really there. I'm still in this like brain fog kind of state. And so there are surveys that might be better to assess that. And people are also now including objective tests like psychomotor vigilance tests into these clinical trials. As Claire mentioned, actually, and Lynn Marie Trotty, who will be here later, and I were on a panel through the American Academy of Sleep Medicine to evaluate the treatment efficacy of medications. And this is really just meant to be a guide to evaluate how good is the evidence that we see, and can we make any recommendations to provider and care patients, people who are caring for these patients, about whether a drug is useful or not based on benefit and risk. So based on that, just quickly, modafinil received strong recommendation, meaning that there was at least a body of evidence that supported benefit over risk. And then there were conditional recommendations for clarithromycin, methylphenidate, pitolisant, and sodium oxybate. And this was really because there just wasn't a lot of literature, but it did show benefit in that small samples that we were able to say that suggested there could be benefit. And just to highlight that this was all done before the acceptance of Xywav for idiopathic hypersomnia, or low salt oxybate for idiopathic hypersomnia, which is now FDA approved. And so this has basically been the only FDA approved therapy we have currently for idiopathic hypersomnia. And it essentially works, we think, by increasing GABA in the brain, so consolidating sleep and improving sleep. But it probably does something more that we just don't know what, because it also really does improve daytime wakefulness and helps with other endpoints that were studied in this clinical trial, which included factors on the idiopathic hypersomnia survey, so sleep inertia, long sleep duration, quality of wakefulness, quality of productivity during work environments, and people feeling like they just had more wakeful time during the day. However, there were side effects of the medications, and there are the potential for misuse and abuse. Fortunately, there weren't any serious side effects in this clinical trial, but it is part of a REMS safety information or risk mitigation program. Minor side effects were common, almost 80%, and those included things like nausea, headache, dizziness, anxiety, and appetite suppression and weight loss. So you'll be hearing more about this, I think, in other therapy talks. So now with all of that, we get to sort of what are the emerging therapies. And as I mentioned, orexin compounds are certainly something that are of great interest in narcolepsy. We know that in narcolepsy type 1, they're missing orexin, but orexin, again, is a very powerful wake-promoting neuropeptide that could be helpful for any group that's experiencing hypersomnolence. So one study that was done is a phase 1 study, again, dose finding, and this was done with sleep-deprived healthy participants looking for safety profiles as well. And so here they gave these healthy participants a medication dose of Orex 750 at 11 p.m. So they're basically using it to keep them awake. And then they're giving them those momentary sleepiness scores and the MWTs throughout the night to see how wakeful they can be during the nighttime period. And so this is maybe a little confusing, but in the blue is placebo and red is the study drug. And just to summarize, essentially the placebo patients, people who are getting essentially a sugar pill, fell asleep pretty quickly. They started out at maybe 25 minutes, they were able to stay awake, but by the end of the night, they were falling asleep within 5 or 6 minutes. In contrast, people on the study drug in red were really able to stay awake for most of the night. So you can see that they were awake for almost 40 minutes, the top ceiling bar on that test. And then even by the end of the night fell somewhere between 30 and 40 minutes. Similarly, the patients or the participants that were on in the study group also were able to say that they felt more awake all through the night compared to placebo. Another compound that was investigated recently was an IV formulation of orexin. So this was called danovorextin. And essentially it was a compound that was evaluated in 18 to 75-year-old patients with idiopathic hypersomnia. Remember, the last one was healthy volunteers that were sleep deprived. And so this was a compound that was tested compared to placebo. And I'll just summarize quickly to say that this showed improvements, significant improvements on that maintenance of wakeful test. People were almost able to stay awake for up to 40 minutes. Also showed improvements on momentary alertness, as well as improvements on the cognitive tests of the psychomotor vigilance task. So very promising. And then last, there was a phase 1b study by Alkermes. This is ALKS 2680. And essentially, this was a sort of a different type of trial, working primarily with patients with idiopathic hypersomnia, though, again, small groups, looking for safety, looking for dose finding. In this trial, patients were randomized to be in a group where they started on placebo, low dose, high dose, medium dose, and then randomized at different schedules of those dosings. Essentially, on the MWT, the maintenance of wakeful test, they found significant improvements at all doses of the medication. And you can see that in purple is the moderate dose, and in green is the highest dose. And when they're nearly at the purple or the green bars, the moderate or high dosing, they're reaching above that 30-minute cutoff, which would be essentially normal. So very promising data. Collectively, all of these medications, substances have shown that there are minor to moderate side effects. And at least for the oral formulations range somewhere between 11 to 33% and are certainly dose dependent. But the common side effects that were reported were insomnia, something called polyuria, which is increased urinary frequency or urgency, dizziness, and rhinorrhea, nasal congestion or runny nose. Importantly, there were no kidney or liver effects, which is something that an earlier compound of orexin agonists were shown in narcolepsy type 1. And so this is very closely monitored in these clinical trials. Unfortunately, no signal was seen. So as you'll probably hear throughout the conference, there are now orexin trials for idiopathic hypersomnia that are recruiting patients. One is through Centessa, the Crystal 1 study, and another is the Vibrance 3 study, which is actively recruiting idiopathic hypersomnia patients. Just in terms of comparisons, I don't know the details of either, but open extension studies allows people to basically continue on a drug for a period of time after the study is completed, and Vibrance 3 does have an extension available. So I put the websites here so you can find out more information. Last year at the sleep conference, a different compound called servodexamethylphenidate, this is a prodrug of methylphenidate, was reported. Essentially, this is a prodrug, meaning that it's a methylphenidate, a stimulant wrapped in something to prevent its release immediately. And so this is taken at nighttime and then releases slowly in the morning. And then again, they could dose it in the second part of the day. This study was done in a small group of idiopathic hypersomnia patients and found to improve daytime sleepiness, but also showed some clinically meaningful improvements on the IHSS, the idiopathic hypersomnia scale, and brain fog. Side effects just were like very similar to stimulants that some people in this room might be on: insomnia, headache, anxiety, decreased appetite, nausea, but no one discontinued the medication due to side effects. So I didn't hear about any updates in that, but something promising potentially. And then last, there was a phase 3 double-blind controlled study of pitolisant for idiopathic hypersomnia, and patients. We were part of this clinical trial. Perhaps other people in this room were participants as well. Pitolisant works through the histamine pathways as opposed to the orexin pathways we've highlighted thus far. And essentially what pitolisant was used was approved for narcolepsy for daytime sleepiness. So this was a trial to evaluate daytime sleepiness in IH patients. In this study, there was an open label phase where participants were basically asked to take the drug, and there was a dose finding period and then a stable period over an 8-week period. And during that time, from the start of the study off of pitolisant to the end of the period of just trying to find the right medication dosing, there was a 9.4 point improvement on the Epworth sleepiness score. And that significance met all measures. So other things like the idiopathic hypersomnia severity scale also improved. However, during the randomized control period, this is where participants were either randomized to placebo or to stay on study drug, there was no significant improvement. They also had an open label extension period of up to 52 weeks, meaning after the study was done, people continued to take the drug just for, is it efficacious? Are there any side effects? And importantly, compared to baseline, there was a significant improvement in daytime sleepiness over this long-term range, as well as the durability of that improvement really was sustained over that 52-week extension period. However, because it did not meet its primary endpoint, that randomized period, the FDA chose not to approve this. Other upcoming idiopathic hypersomnia clinical trials include a phase 3 clinical trial, which is a once-nightly oxybate, FT218 from Avadel. This is an 18-week study, basically assessing the efficacy of just the once-nightly formulation. And here's more if you want to hear about it. In contacting the Harmony group, they do have a next generation of pitolisant medications that they're hoping to run through in clinical trials. So stay tuned. All right, just checking the time. I think I'm going to briefly run through narcolepsy as well, although I know it's going to be covered in other talks. There's a lot more therapies that have been studied in narcolepsy, especially narcolepsy type 1. And so based on the clinical guidelines, medications like modafinil, pitolisant, oxybate, solriamfetol, armodafinil, dexamphetamine, methylphenidate have all been given approval for use. The ones with strong next to it are ones where there was a substantial body of evidence suggesting that there was benefit over risk. This was, of course, before 2021, so once nightly oxybate, low salt oxybate were not evaluated at the time, and pitolisant for children wasn't evaluated at the time. But modafinil and oxybate were also recommended for use in the pediatric population. In terms of emerging therapies, this is really hot off the press. Just this May, there was publication of oviparexin. This is an orexin 2 agonist, similar to what you saw tested in the IH population. This was a phase 2 study done by Takeda. The compound was called TAC-860 for narcolepsy type 1. In this clinical trial, participants, adults with a mean age of 34 and about equal sex distribution between women and men were included, and they were either randomized to a low dose of twice daily medication and then various formulations of the twice daily, so different dosings of that, and then a once daily 7 milligram dosing compared to placebo. And on the MWT, essentially all of the doses met the statistical endpoint of improvement on the maintenance of wakeful test. And you can see the change score here where people had an improvement ranging from 15 minutes to 25 minutes on that maintenance of wakeful test, which is very large effect size. And obviously, again, significant compared to placebo. In bold are the significant results, suggesting that the results are beyond chance. So here, in terms of the Epworth Sleepiness Score, there was a range of improvement based on dose, ranging from 6-point improvement all the way to 13-point improvement. These are, again, very large effect sizes. Cataplexy improved, but only at the 2 milligram twice daily or the 2 and 5 milligram daily medications, and not at the once daily medication dosing. And then the narcolepsy severity scale, which is sort of a global scale of various symptoms associated with narcolepsy, symptoms as well as function, had substantial improvements at all doses. So very promising. The adverse outcomes, however, were ranging between 32 to 91%, depending on what we were looking at. But most of the side effects were mild to moderate. 4 to 14% did report serious side effects, and that included cataplexy, insomnia, headaches, and just headaches. Insomnia, I think, is the one that when I talk to patients, they really kind of are worried about. They're worried that they won't get this good quality of sleep. At least based on this clinical trial, the frequency of insomnia was 22 to 65%, and it was dose dependent, meaning at higher doses, the insomnia was worse. And most, at least in the clinical trial, they did report that there was improvement in the insomnia after the first week of taking it. Other side effects were increased of that urinary frequency or urge, hypersalivation, just increased saliva in the mouth, headache, and nasopharyngitis or runny nose, rhinorrhea. Importantly, there were no dropouts due to these adverse effects. And importantly, there was no renal, kidney, or liver effects that were monitored, that were noted. So there are a number of future and upcoming trials for narcolepsy type 1. There's orexin 2 agonists. So all of these are orexin 2 agonists, I should say, and all of them are in adults. The oviparexton that I just mentioned recently completed its phase 3 study, and there's an ongoing extension study called Move Up. Harmony Biosciences is presenting an abstract here in a mouse model. Alchemies is recruiting for their study for both narcolepsy type 1 and narcolepsy type 2 in phase 2 studies that we'll find out more about shortly. And Centessa is also running a phase 2 study for narcolepsy type 1 and 2. Reboxetine is a newer medication. Actually, it's an old medication that's now coming back. So it used to be used for depression, and it's used across the country in other countries for depression use, but it wasn't FDA approved here. It's brought back and being used potentially for cataplexy control. So this was a compound that acts 12, essentially. Reboxetine was the study compound evaluated compared to placebo. And in this clinical trial, there was improvement in the cataplexy control based on a weekly cataplexy diary. So you can see that the placebos in gray and the purple is the reboxetine. And so patients had a substantial improvement in their cataplexy. So by the end of the trial, people on placebo, their cataplexy did decrease from baseline, which I think is interesting, but was somewhere between 10 and 15 events per week. And those on reboxetine had an improvement of about, or only had about 2.5 cataplexy events per week. And so we can talk about maybe why that you see such an effect with placebo, which is interesting. But overall, the reduction in cataplexy on placebo was 65% and on reboxetine, 83%. And then there was also some improvement in a measure of daytime sleepiness, but it wasn't the Epworth, but suggested that it could be useful for sleepiness too. Adverse side effects included dry mouth, nausea, constipation, paresthesia, numbness or tingling, and decreased appetite. There was one dropout for side effects. I mentioned before that orexin 2 receptor agonist by Alkermes is also being studied in narcolepsy type 2, so narcolepsy without cataplexy. This was a similar design as the idiopathic hypersomnia study I showed you, and the results were quite significant and very comparable to sort of the IH findings, with improvements on that maintenance of wakeful test at all doses tested. So as I mentioned before, side effects were very similar to what we have already seen: insomnia, urinary frequency, dizziness, but there were no serious side effects and no dropouts in this small trial. And again, there is now a phase 2 study being recruited for. Other clinical trials really that are ongoing or going to be newly reported at this conference include things like the phase 3 pitolisant study for fatigue. So fatigue is very common and oftentimes not really well addressed with medications. So this is something that might be coming. And then the duet study from Jazz Pharmaceuticals is looking at the effect on sleep quality using oxybate, potentially for a new indication for the drug. So in conclusion, IH pathophysiology in narcolepsy type 2 is unfortunately unknown, but a subset of patients might have a genetic cause or a problem with circadian rhythm function. And I think that makes it certainly worth further investigation. I think a lot of people, perhaps in this room, have participated in activities through the Hypersomnia Foundation, such as patient voice activities, where basically you're voicing your complaints or concerns or lack of or frustrations really with the lack of progress in idiopathic hypersomnia. And I do think that that was heard. So new treatments are on the horizon. I think most promising seems to be orexin 2 receptor agonists, at least based on the effect size on daytime sleepiness. But the clinical trials have to be done in order to really know, but promising certainly. There are future cataplexy treatments that seem to be on the horizon with reboxetine as well as orexin 2 receptor agonists, and really do consider participating in clinical trials. It's really the only way to move the field forward. Thank you. So I think we have a few minutes for questions, and I think some have come through a chat.
Hi, Dr. Maski. Fascinating presentation. We do have a couple of questions from our virtual attendees. The first question is, how is cognitive dysfunction, for example, brain fog, how's that being quantified and addressed in treatment trials?
Yeah, so I think there are different ways of doing it. Brain fog is a term. We don't really know what that actually breaks down to and to what should be tested. But there are surveys that basically quantify feelings of mental fogginess or cloudiness in different situations that can be helpful. But there's also objective tests that are being used. I would say the psychomotor vigilance task, which is a task of focus. It's where there's like a dot will appear on the screen and then you have to press it, the button, as soon as you see the dot, and then it might wait, 300 seconds or so, and then another one, and then 500 seconds. So it's sort of testing focus and attention. And then there's something called the sustained alertness test, arousal test, attention test. And that is basically looking at sort of a go, no go paradigm where you either press a button for, say, like a number like 3 and not for a number like 7. So there's different ways I think people are trying to approach it. Whether it is truly what the experience of brain fog is a question unknown.
Thank you. Okay, I can ask another question from our virtual attendees. I see a question over here, Rebecca. Can you raise your hand again? Right there. Can inflammatory or autoimmune mechanisms play a role in either IH or narcolepsy without cataplexy? If so, how are these being explored?
Yeah, that's a great question. There has not been any conclusive findings of basically pro-inflammatory chemicals that are associated with like conditions like MS or rheumatoid arthritis or other things that are associated with autoimmune disorders found in narcolepsy or idiopathic hypersomnia. Even within the brain, in brain slices, people who study this have not found any kind of evidence of a reaction in the brain when in people who have this like immune cells that have crossed the blood-brain barrier or anything like that. What has been shown is that at least some patient groups have shown that idiopathic hypersomnia, narcolepsy 2 have higher reporting of allergies and other potentially autoimmune conditions like thyroid disorders, but it's just associations, not really causation.
Thank you.
Hello.
Hi.
Thanks, Dr. Maski, for the presentation. What's the soonest you would expect FDA approval of an orexin agonist and, wide use in the clinic?
Ooh, I wish I knew that. I think that, it is promising that the Takeda study is just wrapping up the orexin 3, or the phase 3 study. And so from there, it can be up to a 2-year process. Typically, it could even be longer. I think these are reasons maybe to write to legislation. I know that Hypersomnia Foundation does have, some potential influence on things like this. Project Sleep's another one. But I think this is where legislators, again, need to hear the patient voice about the patient need to try to just move things forward.
Do we have time for one more?
Please.
Let's see. Okay, one of our
Discuss-
virtual,
There we go. Sorry.
go ahead.
So are there any attempts made during research studies or clinical trials to kind of differentiate between different presentations of hypersomnia? Because it seems to me that it's a kind of a statistical nightmare to try and sort that out afterward. And by identifying kind of subtypes and groups before the studies might lead to kind of essentially different statistical outcomes. So how is that managed?
I think that's a really important point. The problem is that these are rare diseases or rare conditions. And so if you parse it out too much, sometimes you might not be able to recruit effectively for that. So, these trials have been running primarily as, the older drugs, let's say narcolepsy. So they recruit narcolepsy type 1 and narcolepsy type 2. Unless the drug is thought to specifically affect cataplexy, and then they'll recruit narcolepsy type 1 preferentially. With the orexin studies, what we're seeing is that they are parsing out narcolepsy type 1 and 2 because the dose might be different. Narcolepsy type 1, again, does not have orexin, and so they might be very sensitive to the drug. They might need lower doses. With idiopathic hypersomnia, I have not seen that yet. They have the inclusion criteria seems to include MSLT or long sleep duration if that can be proven objectively. And I think we have to see, to be honest, if there's going to be a difference in the efficacy of the medication. It's early days. It's a good question. It's something that I worry about, but we just don't know.
Thank you so much, Dr. Maski. We are at time. Big round of applause for Dr. Maski, everyone.